speakers and panelists are here. It gives me an immense pleasure to open up this webinar in front of esteemed and distinguished panelists that we have for the day. I would like to extend my warm welcome to each one of them, and I would also like to extend my cordial welcome to all those participants who has joined in for this important webinar on vital role of family and community on caregiving. First thing first, I think I will start the introduction of the eminent panelists that we have today for the webinar. I'll start first with Dr. Reddy, who is Deputy Director, National Institute of Social Defense, and who has been spearheading many of the caregiving initiatives that NISD has taken. So Dr. Reddy is into informal and formal caregiving trainings, and he's also spearheads a very important program, which is National Helpline for Senior Citizen, which is Elderline, basically a toll-free number, 14567, and through this number, the elderly grievances can be resolved. And this is a very important program in terms of total outreach, outreaching the elderly persons. So we look forward to your deliberations, Dr. Reddy, and I welcome you to the webinar. Next on the list of the panelist is Mrs. Archana Gautam Sharma. She is founder and managing director, Samvedna Senior Care. She has spent 22 years in the IT field, and she started this caregiving initiative, caregiving platform, with a mission to provide accessible and affordable care services for the elderly persons. And the Samvedna Senior Care is actually a leading platform for mental health and well-being of the elderly persons since 2014. I welcome you to the webinar, madam, and look forward to your deliberations through your experience and the services that you offer through the caregiving platform, the care platform, Samvedna Senior Care. We look forward to your deliberations during the webinar, and welcome.
Thank you.
Thanks. Next in line, we have Professor Siva Raju. I don't think he requires any introduction because I often called him my Dronacharya, and I consider myself as a Glavya. That is the unique relationship that I share with Professor Siva Raju. But he has been truly instrumental in doing and conducting research on aging and aging perspectives. He has been also examining and evaluating various models of care, not only in India, but across the globe. So I welcome you, Professor Siva Raju. It is a sheer pleasure that you have joined us for this webinar. Next in line, we have Dr. Prakash Fernandez, who heads the Palliative Care Partnership at CIPLA Foundation. He has a vast experience of 15 years in the development space, and he's associated with a very unique program, which is ECO, which is Extension for Community Health Outcomes. We are very keen to understand, Dr. Fernandez, from you about this program, and ECO is something that catches my attention because it is related to the health outcomes within the community. It perfectly relates to the topic of the webinar. So we look forward to your deliberations, and I welcome you to the webinar. Next, last but not the least, we have Ms. Sanskriti Khare, who is State Head Helpage India, Madhya Pradesh. She has been leading many of the caregiving initiatives in the states. Madhya Pradesh is one of the leading states which has been running numerous programs in terms of formal and informal caregiving. She has been associated with government also. She has vast experience of 15 years in the development space, and she will be happy to give further deliberations on the caregiving aspect. And she will also be connecting us with the family and community caregiver that we have. So we will have a voice from the ground as well. So all in all, this constitutes the group of eminent panelists that we have for the day. And now I would like to take an opportunity to speak about Helpage India. Helpage India is a leading charitable organization dedicated for improving the quality of life for elderly persons in India. We have been, Helpage India was founded in the year 1978, and we are providing comprehensive care services, including healthcare, aged care, disaster response, elderly self-help groups, and elder rights and entitlements. So this is the work that we have been doing. We believe that the mission we believe in is that we should empower the elderly person and foster a sustainable environment so that they can have a holistic development. With a strong network across the country, Helpage India has been able to address many of the key challenges that the elderly face today and has been able to ensure that the elderly live a very dignified life. Now, further, before I dwell further into the topic of the webinar, it is important to acknowledge the profound demographic transitions that the country is going through. We have 138 million elderly living in India, which is second largest and home to elderly persons in across the world. This 138 million elderly population is going to rise to 300 million in by the year 2050, which will be exactly 20% of the total population that we have today in terms of elderly persons. In a country where 30% of its elderly are either living alone or are dependent on spouse for caregiving and other support, it becomes imperative, crucial, and essential to understand the vital role that family and community can play in establishing sustainable long-term care system in the country. We had a lot of discussion and brainstorming while we were, finalizing the topic for the webinar. And actually, this topic has surfaced from the report that Helpage in India has recently released, and that is available in the public domain, marking the World Elder Abuse Awareness Day, Aging in India. So there were many things that has come out from the report. One thing which was striking, and one of the key findings from the report was about the caregiving aspect. So this was striking feature that came out from the report, and it surfaced. And we thought, let us have a webinar wherein we discuss about the long-term care system, the absence of long-term care system in the country, and the report actually revealed about that 83% of the elderly are primarily dependent upon either children or their spouse for any kind of care they look after. And another 52% of the elderly in the report reveal that they are either dependent on for various activities of daily living and instrumental activities of daily living, and they face numerous challenges in providing support for ADL and IADL activities. So this has come out from the report, and there was a pressing need that we should, do and highlight this issue at a larger platform. And we thought, let us have a webinar on this important topic, which actually takes you to the vital role that family and community can play in bringing a sustainable long-term care system in the country. Now, moving on to the overview of the entire program. So I would like to now share some of the caregiving initiatives that Helpage India has taken, and which has furthered the cause for long-term care system in the country. But before that, I recently come across a triadic model of caregiving, which I wanted to explain and elaborate more on, and how it beautifully relates with the initiatives, which the caregiving initiatives that Helpage India has been taking. So this triadic model of caregiving has three major components. Component one consists of the care recipients, the elderly person, the vulnerable one, the disabled one, the one persons who requires assistance in ADL and IADL activities. So this forms the first component of the triadic model that we have in caregiving. Second component comprises of family and community caregivers, which is often informal, often unorganized, and often unpaid. The third component of triadic relationship is the institutionalized care, which is more formal, more organized, and often paid. So these three components makes a triadic relationship with each other, and it is very important for us to understand this triadic relationship. And it has been said that if we want to make sustainable, robust, long-term care system across the country, across the nations, and across the globe, then we have to give equal importance to each of the components that is there in the triadic model. So equal importance and equity is something which we look after in all the programs that we run. And this is what Helpage India has been very beautifully doing for past a decade now. So we started off the caregiving initiative with a home care pilot project that we run. We started off this program in the year 2017, which aimed at providing geriatric skills to the family and community caregivers, and we trained various members of the community, including the resident welfare associations, senior citizen associations, and we created a cadre of family and community caregivers through this program. This program has shown many tangible results and a great impact in the society. And we thought of using this model and to other programs which we were running. So we infused this home care component into the project Astitva, which is again one of the largest program that Helpage India runs in terms of providing financial independency to the elderly persons. The aim of the project Astitva is to provide financial independence to elderly persons by creating elderly self-help groups. We thought that the component of health was missing in this entire structure of the program. So we thought and infused the home care model into this component of the entire program, and we started providing training to the community members, and we were able to create another cadre of geriatric caregivers from the community itself. The third and the recent program, which is very important to us in terms of reach out, is Project Vayu Uday, which is an integrated program for older persons. And through this program, we have actually adopted 56 villages, and we are trying to create a pool of Vrid Sahaks, the caregivers. We call them Vrid Sahaks. So we are training and we are providing training to the family and community caregivers, and we are building a group of Vrid Sahaks within the community, within the most remote areas of the villages. We have reached out and we are providing care and training to them. Combining all together these three programs, we have been able to create a cadre of 5,000 caregivers who are providing services to the elderly doorstep to almost 15,000 elderly persons across the length and breadth of the country. So this is the amount of reach in terms of the programs that Helpage India is running. We also run a very formalized program where we do training with the unemployed youth that we have. So we do have hospital partners across the nation, and we have identified 15 to 16 partners who are providing formalized training in terms of caregiving to the unemployed youth. In that way, we are benefiting the unemployed youth as well as the direct beneficiaries, the elderly. Apart from that, very recently, WHO has declared mental health as global health concern. And after COVID-19, we started this program called Sarthak, which aims at building the capacity of family and community caregivers and ensuring the mental well-being of elderly persons. So we started off this program, and we have an aim of creating another cadre of 10,000 caregivers across the country. And we have been implementing this program for now 1 year. It is going to complete almost 1 year now. And before I actually conclude and get directly to Dr. Reddy, I just want to state one more thing here that there are four kind of people in this world: those who was a caregiver, those who are currently a caregiver, those who will be a caregiver, and those who will need a caregiver. I think with these words, I will move on to our first esteemed and distinguished panelist for the day, Dr. Reddy. And we would like to know more about the government initiatives that the caregiving initiatives that government is taking. So over to you, Dr. Reddy.
Yeah, thank you. Thank you very much, Rohit ji. Audible, sir?
Yes, please.
Yeah.
Pretty much.
Good morning to one and all. Especially, thanks to Helpage India. Helpage India, since 4 years, they are collaboration with our institute, and now they are recognized as a regional resource and training center from our ministry. And Helpage India is running more than 8 states. This national helpline for senior citizens. That's we called Elder Line. Especially inviting for me for this program. Thank you for Helpage India. See, NAST started in the year 1960-61. Under the originally, this is a setup as a Central Bureau of Correctional Settings. Then in 1964, this is transferred to the Department of Social Security, and 2002, this is become an autonomous institute under the National Ministry of Social Justice and Empowerment. NASD is mainly, this is a nodal training and research center. Professor Shivaraju sir also in our one research advisory committee member. And we are conducting so many different programs as per our annual action plan. See, NASD is a mainly advisory body for the Ministry of Social Justice and Empowerment. We are supporting to all the programs and the policies, making the policies related. And we are licensed with the state governments, NGOs, and reputed organizations, state, national, and international level also. And mainly, NAST develops preventive, curative, and rehabilitative tools, programs, and policies, especially in the field of social defense. It means that is including transgender, beggary, senior citizens, and prevention of drugs related. In that, senior citizen division is one of the prime division in NASD. As per our annual action plan, every year we are conducting different so many different programs. Actually, we are conducting one-day awareness programs on elderly issues like on diet and nutrition, one-day awareness program on Maintenance Act, Maintenance and Welfare of the Parents and Senior Citizens Act. That is, we are conducting training and sensitization programs to the judges, police academies, general publics, government officials. See, for our each program, that beneficiaries are different. Multiple beneficiaries they are including. And we are conducting one-day awareness program on holistic health. Here, mainly, we are focused on yoga and physiotherapy related. And we are organizing one-day awareness program on intergenerational bonding in schools and colleges. Because nowadays we have a huge gap between grandchildren and grandparents. How to fill that gap? What is the role of grandparents? What is the role of parents and grandchildren? Based on that, we are conducting so many different programs. And we are conducting one-day awareness program on government policies and programs. See, like that, we are conducting one-day awareness programs, and we have 2 days programs. Means we are conducting, organizing national, international, state level, regional level conferences, workshops, and seminars on elderly issues. And 3 days programs, that is the residential training programs, that is 3 to 5 days of program training, residential training programs we are conducting all over India on geriatric care, on geriatric counseling, on care and management of dementia related. See, like that, we are conducting 3 days programs. And mainly for today's topic related, we are conducting 1 week family members training, geriatric care training we are giving. See, in this, mainly we are focus on basic how to take care of the parents, how to use of assistive devices, caring procedures like how to check BP, how to check sugar, how to use assistive devices, first aid related. Okay, all this and the basic how to take totally how to take care of the parents, bedridden patients, like that. 1 week, this is a small program we are conducting to the family members. On this, we are tie up with the Commonwealth Commonwealth Education Media for Asia, SIMCA we are calling. We are type with that, and now we are preparing small videos also how to take care of the seniors, bedridden patients. And mainly other, this one is a 3 months course. We have a, we are conducting all over India 3 months course on bedside and geriatric caregivers training program. In that 2 months theory and practical. See, eligibility is who they are completing 12th pass, they are eligible for the admission, and 18 years and above. Age minimum age is 18 and above. In this 3 months course, more than 150 hours theory and 180-hour practical, along with orientation visit we are organizing. Means 2 months theory and practical, and 1 month is on-job training. Means compulsory they want to work in the hospital setup. In this 3 months course, mainly we are focused, see, this is like a combination of geriatric and gerontological issues we are conducting. Means health aspects, and other side is communication, diet and nutrition, yoga, physiotherapy aspects also we are covering. Means we are taking that sessions. We have a standard module and a curriculum we are following. See, here mainly we are focused on the caregiving procedures, from bed making to dead body packing, like how to check BP, how to check sugar, how to give cold compression, how to give hot compress, then first aid related, how to use all the assistive devices, positions, CPR related, diet and nutrition related, and mainly communication and empathy related we are taking classes. Almost all, more than 38 to 40 caring procedures we are teaching, and we have very good classroom facilities, and we are showing some videos also. After completion of the 3 months, then we are taking the assessment, and the next day we are giving the certificate, and the next day itself we are calling the placement agencies for the job placement. More than 85-90% easily they are getting the jobs, but 10% sometimes the students also they are not showing interest for going jobs and other. That is our Indian mentality also. And another one, we have a 1-year PG diploma on integrated geriatric care. See, in this 1 year PG, who they are completed any degree, they are eligible for the admission. Why we are, see, this is integrated geriatric care. Why we are calling is integrated? We are integrated geriatric and gerontological both issues, means health one side, other side social aspects, psychological aspects, economical and research aspects. Research subject also one we have. This is like a managerial course. See, then other we introduced, newly we introduced two advanced courses. That is, one is palliative care and another one is care and management of dementia. See, for this advanced, that is a 1 month course. The eligibility is who they are completed this 3 months course, they are eligible for the advanced course, or who they have a nursing background and minimum 6 months to 1 year experience. They are eligible for this palliative care advanced course and the care and management of dementia. Then no need to tell this one palliative care and other this one. See, palliative care is specialized medical care for people living with a serious illness. See, generally in publicly we are speaking like a cancer patients, that type of this one, but that is like a serious illness. These types of care is focused on providing a relief from the symptoms and the stress of the illness. Here, the main goal is to improve the quality of life for both sides, for patient and as well as the family members. And this is here also includes hospice care also, where that is included. And here mainly in our trainings, mainly we are focused on what is the role and responsibilities of the geriatric caregiver. What are the do's and the don't do's? We are specifically, we are mainly focused on that. This one means the caregiver should courteous to all, especially in the senior citizens. Most of the senior citizens, they are facing loneliness, helplessness, and so many mental health issues. And in the elder line, this one also I want to share one small this one. In elder line also we are receiving so many phone calls related, counseling related. And some, see, senior citizens directly, they are not telling their about their problems. See, first they are telling about their experiences and other. After 1 hour, 1.5 hours, they are telling their, slowly they are telling their problems, like abusers, including abusers also. In so many senior citizens also facing abusers in the, within the family, because children also sometimes they are asking, okay, right will and related property registrations and post-retirement problems for that type of this one. See, generally we are also observed senior citizens what they want to ask. When they are talking, they want to need one person for listening their words. Okay. For that one also, we started the podcast that is successfully within 8 months. We recorded more than 1,628 recorded. Senior citizens only recorded, senior citizens only edited, senior citizens only they published myradio live.com. That is also some senior citizens shared very good experience. Okay. Then especially mainly we are focused on what is the roles and responsibilities of the caregivers, mainly the courtesy to all, be polite and talk softly and gently with the patients, especially senior citizens. And what they are telling, they want to listen the words. Okay. All that this one we are telling to our geriatric caregivers, students, when we are taking the training sessions. And other, we are running some schemes like Sage, that is any company or organizations, NGOs. Uh, if they have any innovative products or services for them, we are up to 1 crore rupees we are supporting. And earlier we have a sacred one portal, that is a senior citizens able re-employment and dignity. In that, more than 2,238 companies were registered who they are seeking the jobs for them. They that companies they provided jobs based on their experiences and qualifications. Uh, like that, NIST is organizing so many different programs. And another thing is we have research wing also separately, and we are conducting so many research projects, especially and elderly issues. Uh, and in that, most of that, this one related to health, like dementia care and palliative care related, they conducted the research also from our NIST side. Especially this family caregiver training is very important, because see, all the family members, they can't afford the professional caregivers, because one is a social stigma, another one is a financial matter. Because of that, so many families, they can't afford the family professional caregivers, and they don't know how to take care of the parents in senior citizens. That's why in that way also we are mainly we are focusing on in that field also, in that area. And we are conducting so many different programs for the family members in pan India, all over India. We have through the reputed organizations, RRTCs, regional resource training centers, and some we have more than 25 collaborative agencies. Through that, this one we are organizing the programs. Thank you very much, sir.
Thank you very much, Dr. Reddy, for elaborating on the various programs that National Institute of Social Defense is implementing with the help of NGOs and other partners that NIST do have. I would also like to understand from you that I am aware that there are many programs that you run online. There are some course modules also that you are giving,
Yes,
and
sir. Under Tapas, we have a separate platform for online courses. That's called Tapas, training for augmenting and productive services. In that, two type of related to senior citizens, two type program courses are there. That is like awareness related. In that, we have very good videos, sir. We selected very good resource persons all over India, and that's videos are very good, frankly. I'm telling you. One is on geriatric care related, another one is on care and management of dementia related, sir.
so I was thinking, Dr. Reddy, if we can have a program, online program, which is exclusively for family and community members, because what is happening, we have various programs, online programs that addresses the problem from the institutional angle, linking them, most of the caregivers with the market, and then providing care at the elderly doorstep. So we're looking at the pivotal role which the family and community can play in uplifting the long-term care system in the country. So, can government think on those lines where we have a program which is exclusively for family and community caregivers, and which could be delivered both, hybrid mode. We can take it online, we can go into the field, and we can provide training, not so long training, but a 3-day or 5-day training program. So are NISD thinking to those lines? What are your opinion on that?
Sir, actually, for this financial year, we want to train more than 1 lakh. Our target is up to 1 lakh. We want to train the caregivers, the geriatric caregivers. That is one side. And right now, in under our ministry, 604 senior citizens homes are there, sir. But we don't have a long-term care centers. From the our ministry, we are planned to start a long-term care centers. In that way, we are that's under the program process. Okay.
Thank you.
Probably very soon we will plan to start Means through the organizations and state governments, we want to start long-term care centers.
Thank you, Dr. Reddy, for sharing the great initiatives that NISD has taken. I'm sure you are making a great impact on the ground, and we would be further listening to you during the webinar. And there are a lot of questions that will be coming in the Q&A box that I will be asking during the course of the webinar. So thank you very much for your insightful deliberations. Next, I think I'll move to
Thank you
Mrs.
very much, sir. See, under our one scheme is there, that's called a PM Special. That is a purely for the geriatric caregivers. Any who they are registered under the HSSC or Domestic Work Skill Council related geriatric care. Okay, if they are interested, they can apply in that portal. Then accordingly, we will give the programs for organizing these training programs, especially
Sure.
geriatric care related.
Sure, sir. Thank you for notifying this. I mean, many of us are listening and would like to, enroll themselves for the programs that you have elaborated on. Next, I think I'm happy to invite Mrs. Archana Gautam Sharma, who is founder and managing director, Samvedna Senior Care. Welcome, madam. And I would like now you to give your opening remarks about the various services which the Samvedna Senior Care is giving in terms of the care platform that has been established now for a decade. So over to you, madam.
Thank you, Rohit. Thank you so much for inviting me and giving me the opportunity to share my views on this very important discussion which we are going to have today. And good afternoon, good morning to all my distinguished panelists and all the audiences who have joined us today. So Samvedna Care is an organization we have been working for the last 10 plus years to help elderly both in their physical, emotional, and mental well-being. We have been working extensively in the area of dementia care, helping not only the individual but also the families. We run certain excellent home care programs, family counseling programs, as well as online, support groups for people whose family members are struggling with dementia or any other, age-related disorders, including mental health. Samvedna has done some extraordinary work in the area of caregiver training. So, especially as one of our panelists mentioned, so caregiving is not just about physical care, but it's a lot about the kind of communication skills you are applying, the kind of sensitivity you demonstrate, the kind of support you give to, elderly in IADL activities, right? So you spoke about that, Rohit. And how you can create an environment for them which is not judgmental, which is not making them feel self-conscious or stigmatized. So our programs have been very well received. We have actually got acknowledgement for them in international forums. We have got recognition for that. Our dementia care programs are also focused on, retaining the cognitive faculties. As you know, dementia is a neurodegenerative disorder. So we really propagate this whole aspect of early detection of dementia. And in that context, we work in creating awareness programs. We have a tool which we have where people can come and evaluate themselves and and take a self-assessment on dementia. They can also take a self-assessment on if they're facing caregiver burden, and then we have the support infrastructure to help them, deal with their issues. In the whole dementia care space, we work on the aspect of mind stimulation, exercising the brain as the latest language, which researchers, and you are one of them, Dr. Rohit, is really propagating brain health. So that is another way of destigmatizing, mental illness or mental health issues or dementia. And our endeavor is to see how we can take this message to more and more people, either through our services or through the awareness drives which we run from time to time, in online, offline, in different communities, in different kind of institutions, to help sensitize individuals about elderly care, about dementia, and then support families in this whole caregiving journey. Like you talked about the 4 types of caregivers. So a caregiver is often the invisible patient in this whole journey, and whether you are caring for somebody in a palliative care, long-term care, or dementia care and things like that, because the stress, the physical toll and the emotional toll is tremendous, and there is a lack of sensitization about the issue in the larger ecosystem, and that is something we'll talk. I'd like to talk more about that when we get into the discussion. But how can we create a more dementia inclusive society? We speak a lot about that, and it extends actually to a more elderly inclusive society. So these are some of the most popular initiatives Samvedna has been running. We provide services, we have support groups, and then our services are available online as well as in certain locality cities. We are also providing physical care services and other kind of care services. So with that, I would just like to open this up for any questions which you might have. So.
Thank you very much. I would say you are doing a phenomenal work in terms of the overall reach out and ensuring that there is a care platform for elderly persons which they can rely on. And you talked about caregiver training and also about the support that is required in terms of ADL and IADL activities. This has actually come out in our report as well. Most of the caregivers are looking for support in ADL and IADL activities. Now I think our participants have a right choice to take right decision and take right treatment at right point of time. So that is something that has come out of your deliberations. I'm very happy about it. And also you talked about the dementia early detection. That is something very important in terms of early detection and early awareness. So we have been also doing this in terms of various awareness programs that we do. But I think this is something which is on the gray side. We have to be more vigilant about dementia care. So that is something we will also look upon. Sid Samvedna Senior Care being a leader where the Samvedna Senior Care is leading the dementia early detection and awareness thing. So that is something that has come out. I also wanted to understand from you, Mrs. Achna, that based on your extensive work in home care and family counseling, what are the key strategies that have proven effective in integrating family and community support into the long-term care for the elderly? As the topic is all about the vital role that family and community can play in integrating a long-term care system in the country.
Right. See, I think awareness. That is the fundamental thing, because just the understanding the fact that, it is no longer Satar Batar and, Satyana and all that stuff. It's very, very important to create awareness in the family uh, about the illness, about the symptoms, about about the resources which are available to seek help, about how to deal with a person who is struggling with these issues. And this awareness we speak about is at multiple levels. So it's not one is the family, but I think a long-term strategy and is really to see how we can go down to at a school level, for example. Can we create an elderly sensitization program in schools for children to understand what elderly issues look like, what is dementia? Because children can be the greatest educators for their parents, and they can help their parents, their grandparents. They can actually help identify the signs as well, if they are made aware of this. So I think one of the very important uh, advocacy which we would like to really see is that how this whole to create a long-term strategy is to see how everybody is aware about this, starting at the school level, the children in public places, in hospitals and in institutions and organizations. So, for example, in your neighborhood, right? So, is it are the utility companies, your banks, are your airport staff, your airline staff, are they sensitized to these issues? So I think it's about awareness and sensitization. And I know there are various programs going on, but I think there's still a lot to be done in terms of how you can rope in more people from different sections of society to help them be able to support people who are dealing with this. See, because if you're a neighborhood shopkeeper, for example, and we speak a lot about this internally as well as in various forums. If your neighborhood shopkeeper understands that what is dementia, and then if somebody is uh, you know going again and again to that person to buy a certain thing, so then they know that this is something which needs to be flagged, because this person is actually, I'm not making a good sale out of it, but actually this person needs support. And so how is he going to react to that situation? How is he going to address and communicate with that person? So that is important. Similarly, in banks, in public places, banks, maximum number of senior citizens are customers in banks, right? So, are the bank employees sensitized to the kind of uh, elderly issues which are there, right? Are they patient? Are they vigilant? That an elderly is because of cognitive impairment or dementia, they are not getting their accounts are not getting compromised, and nobody is going to take undue advantage of them. So in the these are some of the small examples I can share, where in the long term strategy it is about involving the larger ecosystem, involving more people who are in direct contact with the elderly beyond the family. um, then of course there is this uh, the whole the long-term care plan has to be a very multidisciplinary approach. It cannot be just one aspect of care. It has to include physical as well as mental, and then other aspects of care, which is in terms of physiotherapy or healthy diet, nutrition. All those aspects also need to be taken care of. I don't know if I answered your question, but
No, perfectly. And in fact, I'm glad that you brought it out, the intergenerational bonding part. So that is something which Helpage India has been also doing through the SAVE program that we run, Student Value Education Program. So been inculcating values to the school children, to bridge the gap between the two generations. So that is something we have been also doing, and I'm glad that you brought it out and brought it to the light. And my next question is basically to you about how can we the community-based initiatives further strengthened to better support the family caregivers, and how they can enhance their capacity to provide quality care. So that is something I just wanted to know from you.
So I think technology is a great leveler here, and I think we should, I heard Dr. Reddy speak about certain programs. So I think we should use technology to our advantage to help reach a much wider audience by creating programs, which are educating the family. It could be educating on the illness itself, on elderly care. It could be on communication strategies. And we ourselves have a lot of material on our social media, on our YouTube channel. We keep doing a lot of online webinars, and we have certain training modules also specifically for different aspects of dementia. Because then this technology will help us reach a much wider audience space and educate them about this. The other is how do we create accessibility? So uh, online is good, but then can we have community ambassadors? Like, so we spoke about RWs. Uh, and there is a WHO diagram on creating, dementia inclusive societies, and it even mentions religious leaders. In India, for example, elderly tend, you know, there's a vast, uptake for religious activities. So, are the religious leaders sensitized? Can they support in educating? Can we have programs in those places? Because there you will find the maximum number of senior citizens, and uh, uh, going there, and then you suddenly open uh, this whole information flow to a very different section of society as well, because everybody is not technology savvy, everybody is not very well educated. So then you are you're creating a platform there as well. So that's another thing which I wanted to just highlight. And the third thing for me personally is to really see pediatric care centers in every 5 kilometer radius. This is my vision, and I hope one day I'll be able to contribute to this. But just like you have a child specialist clinic, and you will have tons of them in a neighborhood, you should have a geriatric clinic, which is where people can go and seek help for caring for their loved one, or just getting diagnosed, or looking at medical support. So uh, and also,
I can't help you with that.
sorry, and also be able to provide resources through those channels, because you spoke about home care and the programs Helpage is running, which is there in the villages. And we spoke about how everybody cannot afford home care, right? So how do we reduce the cost of home care uh, is something which really needs to be discussed at length in terms of can these geriatric centers in different uh, places create accessible home care. So and this is really picking up from the Western context, because there are state sponsored caregivers, then there are private caregivers, and then there is institutional care and care homes. So they're all models, right? So I think somewhere we need to think about that middle class also, which is which may or may not be able to afford all the services. So how do we create infrastructure for them, which is affordable and accessible?
Thank you, madam, for sharing the great thoughts in terms of, geriatric care center. So this is something which has enlightened me also, because I'm the one who is looking forward to, a geriatric care center should be there and should be the part of the community. So the accessibility is not a question for the community. So thank you very much for these insightful deliberations. I'll come back to you with the question and answers that we have in the chat box. And thank you very much, ma'am, for enlightening this session. I would now like to move to to Professor Siva Raju first. And sir, this is open for your remarks. And over to you, Professor Siva Raju.
Thank you, Dr. Rohit. In first instance, I'm grateful to you for inviting me to associate in this event. As a researcher, I just focus when we talk about aging issues. As you are all aware that it is still at infant stage when we talk, because earlier, let's say 1960s, 70s, when we are talking about aging issues, it was part of family issues. So we need not focus as a separate entity of 60 plus. So from there, it's a long journey that we are able to come, and where we have a recognition and submission that elderly requires a separate entity on their own. So to that extent, it is a very significant journey in the area of research. But still, what we have to think in terms of moving from most of the exploratory studies, finding out the problems of elderly, we need to more and more analytical studies, exploratory studies, working out some of the experimental research. What are the best practices which can be effective? So for all these things, we need to admit that heterogeneity is the hallmark of India's elderly. There is a huge diversity, and that diversity is so huge compared to any other age groups. Elderly, when we are talking about 60 plus, we are talking about 40 years. So it becomes a very simplistic when we talk that the 60 plus requires a focus. So we need to decompose again, like a young old, middle old, or old, or very well that aging is very fast, accelerated in the case of 80 plus. So in a nutshell, if I say that research in aging in Indian context, we can say it is mostly urban oriented, mostly middle class, and also male dominated. So we need to open up in understanding and giving a special focus on rural and tribal areas or small and medium towns, and also focusing on unorganized sector where 90% of our elderly are there. And furthermore, feminization of aging, which is coming in a big way. So how best we can especially focus on female elderly, because they are experiencing double burden. So how best we can. So some of these vulnerable sections also we need to focus. So research is a long way, it's a continuous process. And in this process, we are very happy now we are talking on long-term care, which is the need of the hour, because as a life expectancy is now giving a, finding that around 20 years, an individual will live after attaining 60 plus. So these 20 and odd years, how best their quality of life can be assured. And in that, research has to help along with the training and intervention models that we need to work it out. But at the end, I would like to focus that one particular model will not be sufficient. We need to have different models given the diversity of elderly who are residing in our country like India, where heterogeneity is a major issue. I hope with this brief introduction, I'm sure when we interact a little more further, I will talk. Thank you.
Thank you so much, sir, for bringing the point of feminization of aging into this picture. Because if we see the family setup, it is only the females who are the primary caregivers. They are providing care to the family members. So feminization of aging is something we are coping with. Earlier it was restricted to the developed world, but now it is catching up with the developing world as well. Further, I would like to ask you questions regarding your experience on the elderly care model through family and community across the world. So, what is the most ideal model which is equitable, accessible, and effective? And I would also like to know how the same can be adopted to address the issue that India faces.
Yeah, thank you, Rohit. If we see some of the countries, one thing which we have to accept that aging and development highly correlated. So when development takes place, there is a automatically aging issues are penetrating because it is a effect of development that we are also getting that fruits of higher life expectancy. Now the question is the major anomaly that exists between developing and developing countries like India is that most of the developed countries became developed in the beginning and then they started experiencing aging. You know very well, like countries like France, Italy, there more than 100 years it took to double their elderly population. Whereas in South Korea, Japan, some of these are very fast emerging countries where the elderly almost double within 12 years, 15 years like that. So the question arises that the speed of aging is phenomenal in developing countries. So we are struggling where our problem is that one side we are not able to provide that much developmental parameters for its access to our elderly people, but we are able to assure them for living longer. Now, in living longer, what about their the things which they have to enjoy in terms of quality of life components, whether it is a social life or economic aspects or the intergenerational bonds. So this is one of the important issues. The other aspect is given the migration, especially young towards urban areas or outside of the country, now that is going to continue and furthermore increase. So ultimately, the elderly are left out. So when we talk about most of the developed countries, there is a reasonable infrastructure which has been placed for elderly care, and at the same time, the financial and other facilities are reasonably taken care of. Now, the technology also has assisted them to continue in staying wherever they are and to their limited way to take from their family and community. Now, in the case of countries like India, our struggles are that, as you know very well, that when we are talking about informal care providers, like ultimately the family means, as you rightly mentioned, it is ultimately female person. Female persons are overburdened. Now they are the people who also need their help and also who needs the care. At the same time, they are the caregivers. Now the question arises how best we can address their issues, and at the same time, how best we can bring out several stakeholders. That is the challenge before us. There is no point in blaming a government, or there is no point in saying that some of the NGOs are working in isolation. They are not able to scale their activities because in the limited resources they are doing, and government also has its own limitation. What we need to bring out a good model is how best all the other stakeholders can be engaged, because that we need to bring it out. And keep in mind that aging itself is a disciplinary. There is no one particular discipline can say or claim that through this discipline we can solve the problems of elderly. So transdisciplinary, multidisciplinary is the major focus in the gerontology. So we all have to come together. At the same time, new stakeholders, like for example, we have analyzed the percent of allocation made by CSR groups, which is a new entity in elderly care. Now, to our shock, we found that not even 1%, when they constitute 10% of India's population, hardly less than 1% is spent from CSR funds. Now, the question when we interacted with some of the companies, they said that we are not aware that aging issues are to be prioritized. So, there is a lot of requirement on our part that whether we are researchers or whether we are activists or we are, moving in advocacy role, what we need to do is we have to constantly engage with various stakeholders so that they will be aware of, they will be provided necessary information. So with my own limited interaction with various CSR groups, I found that their knowledge and awareness is very, very low. They feel that no doubt children, women, young age people requires attention, but aging also we need to tell them that look, this is coming up in a big way, you also respond. So constant engagement of, so the model that I propose is that there should not be a unifying one single model, whether it has to be decomposed with respect to localities like urban, rural, tribal, and all these things. At the same time, there should be a separate model which is focusing on male and female separately, and at the same time decompose in terms of their marital status, in terms of their literacy level, in terms of this thing, so that there will be micro models that can evolve. So that we, for example, in Mumbai, we have worked out an action project titled Mumbai Cares for its Elderly. What we did, we have worked out at each ward level. There are 25 wards in Mumbai. So each ward, we have identified all the stakeholders who are working for the elderly issues. So we mapped them and we connected with their addresses. So we reached out to each of the senior citizens groups. Look, these are the aging issues in your ward. So work it out. How best each of you can work it out to solve their issues. So each of these models are very unique. We need to propagate, and we need to, some of the models which I'm sure, like Archana, what she was mentioning and working out, your HelpAge is pioneering institution which is working out. What we need is how best we can scale them and how best we can replicate them in nook and corners of the country, because it has its own, it requires a lot of resources. This is where we need the help of other stakeholders, so that let these issues cannot be mentioned as only for NGOs or only for CSR group or only for government or other agencies. We all have to come together. So we need to create more and more such platforms at a local level, so that all the stakeholders who are interested or who are indirectly working in these areas, we have to bring them together and let us solve what are the issues that their elderly are facing. I'm sure such model will be very good, which can be worked out and it can be taken further. And with all the long-term care that is coming, time is running out. We need to work it out, such models at micro level, at a community level. Yeah, I hope I can be.
I totally agree with you, Professor Sivaraju, on the micro models, because we also believe that small steps can lead to bigger impacts. So we have to evaluate these micro models and how these micro models fits into the community setup. That is something we need to examine. My next question to you, which directly relates with the title of our topic, is about the role that community healthcare workers can play in bridging the gap between community care and formal healthcare providers. So,
yes, this is a very important area which you have mentioned. I'll give my inputs. See, one of the important thing is that, as you rightly mentioned, the community, health staff who are working at grassroots, they are the people who knows the community, especially the elderly issues. What all they want to do is we have to give them more and more emphasis to work it out on primary healthcare model, which can be primary healthcare, which can be affordable, accessible, and acceptable by the community, and by involving multi sources for solving their issues. Now, another important aspect which we need to know is we have done a small survey. For example, healthcare workers, how many people are agreeing that mental health issues also is in their domain? Can you imagine? To our shock, we found not even one person who has agreed that mental health is also one of their tasks. They agreed and they said that mental health is still a familial issue. Let the families take care of. We need not enter into their domain. So we will focus on physical health. So this is another important aspect. But if you see their modules, work schedules, there is a mental health also has to be emphasized. So there is a gross neglect of mental health issues at grassroots level. So we need to group them and we need to connect them to the community aspect. And another important thing is, being at grassroots, they are the people who are the first reference for any health issues. And if that can be, they can be worked out for effective referral service system, where they can, beyond their competence, how best the elderly issues can be referred. I'm sure like mobile medical unit of HelpAge India is a very important attempt, where there is a, medical aspects at a minor leisure you are solving. At the same time, beyond your competence, the doctors are referring to the tertiary care. So these are the things. So how best these health workers can join with the other agencies at grassroots, so that they can help in working out in consultation with other agencies, ultimately to see that their issues can be also solved. And also they are the people who can be more as a counselors also. When we are talking about caregivers, especially the young people, their issues also, they can act as a counseling like that. So they are, I think, first referee, that they are the people whom we should effectively utilize. And in this, LPG is doing good work of creating that cadre of health staff so that they can work at community level and they can solve this thing. And I fully agree what Archana is mentioning, that within 5 kilometers or 3 kilometers, can there be a center? Because our own experience in Mumbai, we found that even daycare center, beyond 1 to 2 kilometers, elderly are not able to go. There is a daycare center. But the question is, how are you going when the transportation is so bad and road connectivity is very low? Young members themselves are discouraging them not to venture out of the house. So how best the transport network can be worked out so that this at local level, these centers can be effective, so that the elderly will find value for coming out and interacting. And that will enhance greatly the social participation of elderly, and their loneliness can be addressed to a great extent. I hope I conveyed, Rohit.
Thank you, Professor Sivaraju, for throwing the light on the proper topic and also for your deliberations. I always admire talking to you as Eklavya, and you are my Dronacharya.
You are
Thank you
all
very much.
committed. You are the future, and I am very happy that it is in the aging is in safe hands. All of you now it is working, and your dedication I fully appreciate.
Thank you very much for your blessings, sir. And next, I'll think I'll move to Dr. Prakash Mendendis for his opening remarks, and then I'll follow up with some of the questions that I have.
No, thank you, Rohit, for inviting us to be part of this webinar. I'm equally delighted that palliative care has been mentioned several times already, because generally palliative care is an oncology conference at the last session when everybody is falling out. And I think this is really an issue which, as Dr. Reddy pointed out, is about anybody with a serious illness, because it faces challenges not just physically, but emotionally, socially, spiritually as well. And I think the distinctive part about palliative care is it addresses that holistically. So it doesn't just look at the illness really, but it looks at the person and how it's really impacting on their daily life. And equally, it's looking at the caregiver. And as already been mentioned, is the caregiver is equally a patient in many ways, invisible, neglected. And palliative care makes a conscious attempt, therefore, to ensure that the caregivers are brought into this. And I think, as Dr. Sivaraju said, there's a big diversity in this. There's a whole range of socioeconomic background, gender. Palliative care really tries to tailor make, I think, that care to really suit that patient's circumstances, which are so different. From living in a slum to living in a flat in a high-rise building. What does palliative care therefore do? And I think our journey at Cipla Foundation began in palliative care with the setup of a palliative care center in 1997, so over 27 years ago in Pune. And of course, it had a multidisciplinary team focusing on oncology. But one of the unique features of that model was that it had a family care model, in which it was encouraged that the family member also accompanies the patient while they are there. It was called the Palliative Care Center because, yes, palliative care is not end of life. And I'm really glad that's really been highlighted, but should really begin as early in a diagnosis as possible. And the family member, therefore, is part of the journey and needs to be attended to. I think your HelpAge report actually has highlighted something about the physical needs, which are really important because, when you're asked the elderly population in your sample about how their health was, actually 10% said poor or very poor in a self-report measure. Of course, that increased when people were above 80 to about a quarter. But actually, when people were asked did they suffer hypertension or diabetes, that was about 50%. When people were asked about any aches and pains, osteoporosis, that was about a third, 30%. People having NCDs and multiple kind of two comorbidities was over 50%. And I think that's what it is sometimes in palliative care, that you feel you have to live with that symptom. You accept it and you feel that perhaps this is part of life. Palliative care really about quality of life is saying, you can address those symptoms. You can treat what's treatable and look at, therefore, how you improve your quality of life. palliative care being kind of a specialization now in the medical field, and you have an MD, a course in palliative medicine, has kind of doctors, nurses who are therefore trained to be able to do that, to be able to look at how the medical aspects of palliative care can really support people through their illnesses and make sure, therefore, that people continue through treatment. So I think uh, definitely with the elderly, palliative care has a great role to play. And I think in many of our projects now that we support, and at Cipla Foundation, where we currently support about 30 partners across the country in 42 projects in about 17 states across India. And we really support them with teams of people, doctors, nurses, counselors, social workers, who therefore are trained to deal both with the patient and with the caregiver. Just coming back to the family caregiving model that we have at our palliative care center in Pune, is that to enable, of course, caregivers to understand how to kind of care for their patient when they go back home. And so that part of training is there. They can actually see it hands on. How are the wounds treated? How do you give the medication? How important it is to follow up? What about posture? But equally, the caregivers also have their own space. So it's a bit of respite for them that they can sleep the night because there's a special dormitory for them to go down while staff can take care of for their patient. And for many of them, that's the first night they've actually had a good night's rest. And they know that their patient is being cared for. Being an inpatient or even in home care really allows for the counselors to have family meetings. I think a lot of times there's unfinished things that have been said. And socially, therefore, how do you get families to talk about things which are quite hard sometimes, thinking about advanced care planning, how do you do that actually? And of course, you have to do it very gradually, but how do you actually prepare and have conversations within families is something I think which a lot of communication is important. So it was really great to hear that, Dr. Reddy mentioned about the course that is available for caregivers, for healthcare professionals as well, which have to really focus on these aspects of how do we really coordinate care for the elderly population? How do we follow that up? I think that's really important because, sometimes we may have a care plan, but they require, as Dr. Sivaraju said as well, what about the transport? How do they get to appointments? This is where somebody needs to coordinate that plan because there may be various things happening. How do we show that's implemented? How do we track that's actually being implemented to improve quality life? I think, therefore, palliative care really comes into kind of being. I think, as Ms. Archana said, if we look at home care, how do you look at cost-effective models? Because how do we make this scalable? How do we reach out to more people on that? And that's something I think we, as a foundation, along with our 32 partners, have been thinking as to how do we do this? Do you have kind of nurse aides at some level? How do you have doctors controlling that? So that there is a quality service that's being provided as well. Because you don't want to already burden perhaps caregivers who are burning out. How do you sense that, therefore, that this is a time for their respite, that this is a time now for a professional to help that caregiver? And when can you step out? I think these are kind of decisions that are really important so that we can also provide quality care to all kind of the elderly population.
Dr. Prakash Fernandez, I completely believe that I'm a firm believer of that, it is not only the quality of life that matters, it is quality of death that also matters. So I'm a firm believer of that. And before I move ahead, I have a specific question for you. Just wanted to understand from you, what are some of the practical steps that families can take to plan and manage the long-term care needs of the elderly?
Yeah, no, I think that's absolutely necessary. And just looking, therefore, from a palliative care lens on how you would plan for this, I think is kind of looking at perhaps physical aspects first for a caregiver. What do they need to look at as they are interacting with the elderly? And I think one is, if people are not reporting pain, is to look for those signs that, when there's a grimace or there's kind of a face of people who are kind of struggling with the pain. And I think that's the time to address it, to be able to name some of the things that you're observing and being able to follow through that to kind of make sure that, there's a medical appointment made or somebody's able to go to that. I think is to kind of be observant to changes that are happening as well in planning, kind of vision, teeth. These are basic things actually, but how are they getting on with their daily life? the activities of daily living, the scale that you used, is that changing or not? What were they capable of doing? Is that changing? So I think practically it's about really being observant about physical changes that are happening, and therefore being able to act on it, being able to go for kind of medical appointments along with the elderly person as far as possible. They don't go alone. As your report also highlighted that several people in several states perhaps have gone alone for appointments, and then that follow-up may differ. So I think one of the big things in palliative care, actually, as you're planning for long-term needs, is to be able to think ahead. And I think if an elderly person falls, their quality of life quickly deteriorates after that. So how do you actually prevent falls? And this is something that, caregivers need to be slightly alert of if there's kind of an unsteadiness. Of course, it's referring to kind of help that is available. There are fall risk assessments that palliative care professionals do as well. I think caregivers need to be alert to this and, to be able to refer or seek help and guidance as to what needs to be done. Should a first fall happen, how do we prevent this from happening? Because palliative care professionals, when they go into a home, can look at the environment as well and see what needs to be done slightly, some slight tweaks sometimes, of kind of handrails being put in so that people can get up, kind of where are the toilets, what is the approach there? If the patient is bedridden, then how do we look at bed sores? So I think that physical aspects is something which families need to be more alert of, highlight, and seek help for. I think we've talked about emotional change, and I think a lot of elderly people will also go through kind of changes through their course. And elderly, as we said, is a huge bracket. But I think it's being able to have routines, make sure that, to check into people, to check into elderly if you're not living with them, to make sure that system is in place. I think intellectually to also be aware of things that may be changing for them, of course, things being repeated often, and if they're getting anger issues, what do you do there? As we talked about dementia, what are your responses as well? How do you react and how do you communicate it? So I think those need to understand, I guess, the person a bit better is really important. Financially, I think you really need to think about as well. And that's one of the things that you look about is planning ahead finance. Where is the person going to finance treatment should something happen? And having those discussions a bit earlier, families need to plan for that as well. So I think it's kind of all those aspects that need to be taken care of as you're looking for kind of practical tips on what to do and manage people as they grow older in your families.
Thank you very much for suggesting these practical steps. I think many of us are listening very, in an interesting mode, and we have noted down most of the practical steps that are required. We'll be able to better navigate the care and support the steps you have suggested. I am very much interested to know about the eco project which you are associated with. So, if you can throw some light on the extension of community extension for community health outcomes project, if you can some.
Yeah, so I think, as we say, palliative care, if it really has to expand and integrate, requires us to have more professionals on board. And so we were associated with ECHO really in promoting kind of the concept of palliative care. And the good thing about ECHO, it's about case-based discussion. So people actually bring cases from kind of lived experience, which you bring in and you discuss that. So you have, kind of a didactic lecture and somebody bringing a case which you look at as what could be done better or not. So that really, the ECHO program helped us as we did kind of courses with physiotherapists, allied professionals. We did it with oncologists. For them really to think about, therefore, how do we get the message? How do we actually practically, as you said about practical tips, I think that's the most important actually. What do we change on the ground to improve quality of life? And I think while, of course, there are some general principles and models, it's so individual. And I think the more we can share, the more we can learn from each other as professionals, the better we can provide quality care to our patients and caregivers. And I think ECHO, therefore, is that platform which allows that peer-based learning in a very safe space to do that. So, we've been happy to kind of do those ECHO programs. Having said that, I think training runs across. And I think the more awareness we can create within the healthcare system, within professionals, and really introducing palliative care in the curriculum, the medical curriculum is so important so that everybody is able to understand and appreciate kind of the value of communication of, that is not just about medication, but asking the patient what more can be done, involving the caregivers, I think, in the treatment because they are going through such stress. So I think if the healthcare professionals and healthcare becomes a little more person-centered, I think that's really the aim of palliative care, to create this ripple effect somewhere with, of course, there's a team embedded in several of the hospitals that we support, for example, in the public healthcare system, is how do we really change that ecosystem within the hospital so that, it's more person-centered and the person as caregivers also involved, and they are being asked what is the impact on them. I know people, professionals are so busy that, we don't have enough time. And therefore, often it's the treating physician who will have the first conversation and say, then you can see another team, a palliative care team, who can therefore address these needs. Whether they call palliative or supportive care teams, these are teams really who are looking at how the illness is impacting the person beyond just the illness.
Thank you very much, Dr. Prakash Menendez, for the insightful deliberations. And next, I think I would like to move to our state head, Ms. Sanskriti Khare. She's been waiting very patiently for her turn.
No, it's okay.
Yeah, so over to you, ma'am. We can start your deliberations.
Yeah.
And,
Good afternoon to all panelists and all the audience. And I would like to start this important issue, elderly issue, with the oldest song, which is lyrics are written in the 58 years old lyrics. That is a सजन रे झूठ मत बोलो खुदा के पास जाना है. There is a one paragraph that is लड़कपन खेल में खोया, जवानी नींद भर सोया, and बुढ़ापा देख दिल रोया. So that time also old age is a very painful for the society, community, whatever they feel that. Instead of that, all the peoples are surrounded, like elderly peoples are surrounded by their family members, their community peoples are always with them, but still they feel it is a painful age. And initially, like in the palliative care duration of the time, like when patients are on the dying stage, at that time all the like family members are chanting Gita with Gita part is with the elderly person. So many things are there to give them peaceful rest of life. But now one couple is there and four elderly peoples are dependent on the one single couple. So there is a huge demand for the caregiving training programs and the caregiver services. I would like to share a few things, initiatives taken by the Helpage India. So I will share one presentation. It's visible. Rohit, it's
yes,
visible.
it's visible.
Yeah. So focus on the role of family in the community in long-term care. Helpage India is running one project, Astas project in Punasa district. We are covering 18 villages. In 18 villages, we have 1,380 elderly persons living in all the 18 villages. So in there, we organized four training program, and in four training programs, we have 120 caregivers trained. Three caregivers are paid by the Helpage India. So all the caregivers are provided caregiving services to the 84 bedridden patients. So all the 84 bedridden patients in 18 villages covered by three caregivers and supported by the 120 caregivers which are based in the different villages. So this is a very different initiative because we have a huge project over there. We have income generation livelihood projects in that particular area. So many people, so there are all three categories are in this project, like bedridden patients, active, and as well as dependent. All three categories are there. So we developed such kind of community to support elderly people who are with the low self-care capacity and unable to move from their beds. And apart from community caregivers, they are trained to their family members who are unable to, like, they don't know how to handle these kind of elderly patients. So they all the caregivers train their family members and the community how to support the elderly people. So this is one of the initiative taken by the Helpage India. And apart from that, what I have listened from the Dr. Reddy's and all like different speakers, they are all are taking different initiative for the elderly persons and specifically for the from the government department. So in these are some pictures from the field, caregivers are providing services. So this is a different initiative taken by the National Health Mission under NPHCE program. So NPHCE cover holistic approach like providing medical services like old age homes, and everything is covered under NPHC. So in this program, so far we have conducted 46 training programs, and in all the 46 training programs, we trained 920 training of trainers, including medical officers. There are 340 medical officers, 580 nursing staffs, and all the technical support provided by the Helpage India to all the. So basically, what our role is that they are all the medical officers. They don't need medical training because they already have a very good qualifications and everything. But what is the missing part, that we got so many feedback from the senior citizens that they, when they approach to any government hospital, so the attitude of the hospital staff is not up to the mark, that what we are expecting or what senior citizens are expecting. Respect, there's lack of respect, there's lack of communication skills, so many things are there. So our Helpage India is taking initiative to give communication skills training program, and how to prevent elder abuse, and apart from that, how to give caregiver training programs to the bedridden patients. So this is our different initiative. And third initiative, and this is the picture of that training program, government training program. All the practical exposure we give practical exposure in the district hospital only, so that they can understand, and this training practical exposure is given by the trained medical officers. And this is a different action plan what nursing officer prepare from themselves. What is their understanding before training program about the elderly issues, and what, how can they solve their issues, but they don't know basic things, like they don't know how to differentiate between the age group of 60 to 70, 70 to 80, and 80 to above age group. So we focus on the particular age group, how, what are the difference, the problems, different problems between the different ages. So this is our initiative. And after training program, what they learn, what they are supposed to implement in their hospitals, so that is also initiative taken by the government hospitals, and they really I appreciate that they all are doing very fantastic job. This is a different training program by the National Health Mission, and that is for the mental health, elderly, and palliative care training program, for the specifically for the ASHA workers. And so far, 140 trainings of trainings already prepared. And in this, Helpage is one of the resource person to provide this training program. And in this training program also, our role is to focus on this specifically for the elderly person, how to handle this elderly person, take care of care, how to comfortable caregiving services, because asha karyakarta are the person who is based in the community and who is overburdened. All the programs are implemented through the asha workers, so we need to sensitize them, we need to motivate asha karyakarta, and we need to sensitize their community. So how to, they are the person who is going to train another 30 to 40% single asha karyakarta. So motivation level of the Karyakarta needs to be enhanced. And apart from this training program, they are supposed to handle different other training programs. Like apart from elderly, they go to vaccination program and so many programs. So we need to sensitize them. The elderly issue is the first important issue. They need to take care of that. This is a different program initiative taken by the Helpage India. This is the training program, some pictures, practical exposures, and the training programs. And proposed recently, we have a discussion with the Social Justice Department, and we proposed one training program, that is training program for the managers for old age homes and the caregiver who are give their services in old age homes. So this is a different initiative we are going to start, and we propose this proposal, and Social Justice Department agreed to take this proposal. So total 79 government old age homes are there in government Madhya Pradesh. And apart from government old age home, we are going to cover 20 to 25 private old age home in this training program. So we propose around 110 old age homes managers as well as their caregivers for this training program. Again, there is a lack of communication and the attitude towards the elderly, because caregivers are there but they don't know how to handle the patients, how to handle the elderly patients. If there is a 90 to 80 old age person in old age home, then at least 10 to 12 persons are the bedridden, and they're totally dependent on the caregiver. So caregivers are there for part-time or for full-time, but they don't know how to handle. Their language is not up to the mark. They even don't bother about their like bedpan and everything. So we need to focus on the particular issues. So this is one of the different initiative proposed to the Social Justice Department. And apart from that, one different initiative that Helpage India is taking, this one example I'm showing, that is, she is a Gitanjali, and she is a trained volunteer. She's based in Jabalpur, and in telephonic conversation, we trained this volunteer, and she was a caretaker for 2 months for this destitute elderly person. He was a like she just saw that person, she saw and called me, and I'll just talk to that person, ki, why don't you become a caretaker for that person? So she's agree for that. He's admitted for 2 months, and every day she went to hospital. Collector, everybody is involved in this particular case, but really they are doing outstanding job. So we need to develop so many young volunteers to support the elderly person for the caregiving services. So there is a huge demand for caregiving services, but luckily we have a huge team, but we have a limitations also. We have a like so many youth, but they are engaged in their own priorities. They have their own system. They have their own uh, way of living. They are involved in their career. They are involving their own future. They don't bother about the person who is living in their next door. He is suffering for the elder abuse, but they don't know about it, and they don't. If they know that, they don't want to enter in their life. So that is the biggest problem with the youth. So requirement of sustainable long-term care is really very important, and family and community need to be involved for that. And last comment is that each and every youth, middle-aged group is the core person. We need to sensitize them and train them. Thank you so much, Rohit.
Thank you so much for showcasing the tremendous work that you're doing in the state. There were some of the pictures were really moving. We were able to connect with some of the pictures because, as I already said, that we all are caregivers, and there are caregivers. There will be a caregivers, and there will be persons who will require care. So thank you for your deliberations for the day, madam. I think lastly, before we conclude for the webinar, I would like to move to one of the community caregiver that we have who has joined from the ground itself. We have Mr. Rupesh, who is leading the project Astitva, and he is standing with the community caregiver, and we would like him to share his experience and what he feels, doing the care, being a caregiver in the community itself. Let us hear from the voice from the ground first. Over to you, Rupesh, and the community caregiver, Mr. Sonu.
गुड मॉर्निंग सर, गुड मॉर्निंग सभी को। मैं रूपेश ताम्रकार, प्रोजेक्ट ऑफिसर पे मैं खंडवा डिस्ट्रिक्ट में कार्यरत हूँ, और मैं सोनू मेघवाल जो होम केयर सर्विस देते हैं गांव में, वो उनसे हम आपका आज से उनको दिखाते हैं और वो अपने एक्सपीरियंस शेयर करेंगे आपको। जी
सभी को नमस्कार। मेरा नाम सोनू मेघवाल है और मैं हेल्पेज इंडिया के केयर गिवर के रूप में फील्ड पे काम करता हूँ। हमारे पुनासा ब्लॉक और आसपास के जो भी ट्राइबल्स एरिया है, छोटे छोटे गांव, वहां पर हमारे कुल 84 बुजुर्ग हैं ऐसे, जिनमें कई बेड रेस्ट हैं और कई बुजुर्ग ऐसे हैं जो कुछ धीरे धीरे चल पाते हैं और जिनको केयर गिवर्स की आवश्यकता है। ये काम करने से पहले हम लोगों के दिमाग में बुजुर्गों की सेवा करने के लिए जो भावना थी और हम उनकी सेवा करना चाहते थे, किंतु कुछ परिस्थितियां ऐसी थी कि हम उनकी सेवा कैसे करें। ज्ञान की कमी थी, अनुभव की कमी थी, हम उनकी मदद नहीं कर पाते थे, और कुछ ऐसी परिस्थितियां थी कि हम चाहकर भी उनकी मदद नहीं कर पाते थे। लेकिन हेल्पेज इंडिया के माध्यम से फिर हमें एक प्रशिक्षण दिया गया केयर गिवर का कि किस तरीके से बुजुर्गों की देखभाल करनी है। बेड पे बुजुर्ग हैं, उनको उनकी कैसी उनके कपड़े कैसे चेंज करने हैं, उनकी बेडशीट कैसी चेंज करनी है, उनको हल्की हल्की एक्सरसाइज वगैरह कैसी करवानी है। ये चीज की हमारे पास अनुभव नहीं था और कोई ट्रेनिंग भी नहीं थी, लेकिन जैसे हमको हेल्पेज इंडिया के माध्यम से कुछ प्रशिक्षण मिला, उसके बाद हमने उनके घर पहुंच सेवा प्रदान करनी शुरू की। क्योंकि एरिया पूरा ग्रामीण है और आदिवासी इलाका है पूरा, इसलिए बुजुर्गों तक एम्बुलेंस या अस्पताल इस एरिया तक नहीं पहुंच, इनकी पहुंच नहीं है। अस्पताल और जो भी अन्य सुविधाएं हैं वो गांव से काफी दूर हैं, इसलिए काफी कुछ बुजुर्ग ऐसे रहते हैं जिनके पास तक ये सेवाएं नहीं पहुंच पाती। तो आज हम एक केयर गिवर के रूप में उन्हें कुछ जो सुविधाएं दे पा रहे हैं, जैसे उनकी बेडशीट बदलना, उनको हल्की हल्की सी एक्सरसाइज वगैरह करवाना, उनको किस प्रकार से उठाना है, उनको शौचालय, उनको टॉयलेट्स वगैरह कैसे करवानी है, उनको खाने पीने की कैसे सुविधाएं रखनी है, उनके टाइमिंग क्या है। एक हमारा चार्ट बना हुआ है कि सप्ताह में उनको कितने दिन क्या क्या सी सुविधाएं देना है, उनको कब नहलाना है, कब उनकी बेडशीट बदलना है, 2 टाइम ब्रश करवाना है। और उन बुजुर्गों को जिनको मालिश की आवश्यकता है, उनको किस तरीके से मालिश करना है, कितने राउंड ऊपर नीचे किस तरीके से हल्के हाथ से मालिश करना है, ये सारी चीजें हमको प्रशिक्षण के दौरान प्राप्त हुई। और हम ये सब ग्राउंड लेवल पे बुजुर्गों को जाके ये सुविधाएं देते हैं। और उन बुजुर्गों के परिवार से संबंधित जो लोग हैं, जो उनकी देखभाल करने में भी इस तरीके से थोड़ा हिचकिचाते थे कि अब बुजुर्ग हो गए हैं, अब उनकी क्या देखभाल करें, अब तो जाएंगे ही इस प्रकार से। लेकिन उनको भी मोटिवेशन देकर कि हम बुजुर्गों की देखभाल करके उन्हें थोड़ा और जीवित रख सकते हैं। और बुजुर्ग हमारे परिवार में या हमारे समाज में एक वृद्ध वृक्ष की तरह होता है, जो भले ही फल प्रदाता ना हो, लेकिन अगर वो आंगन में लगा हुआ है तो एक अ, छांव की तरह तो होता है। इस प्रकार के हम छोटे छोटे एक समूह हमारी उम्र के या उनके परिवार से संबंधित लोगों के बना करके गांव में उनको हमारी तरफ से और हेल्पेज इंडिया के माध्यम से उनको मोटिवेशन देना, उनको सप्ताह में 1-2 बार जाकर के उनकी केयर करना, उनसे आपसी तालमेल जमाना, बातचीत करना। कई बुजुर्ग ऐसे होते हैं जो केवल बातों के या फिर उनको उनसे आपस तालमेल बनाने के लिए ही वो लोग भूखे होते हैं कि यार हमसे कोई बात करे। अनाज के या भूख का तो हर कोई भूखा होता है, लेकिन उनसे बात अगर करते हैं तो उनको एक भावना उत्पन्न होती है मन में कि चलो हमसे कोई बातचीत करने वाला, हमारी केयर करने वाला, मेरी बेडशीट बदलने वाला या फिर मुझे एक सहारा देने वाला एक केयर गिवर जो सप्ताह में 1 या 2 बार आता है, तो हमारी एक भावना जुड़ी हुई रहती है। और फिर उन लोगों को भी ऐसा लगता है कि चलो डॉक्टर तक हम अब नहीं पहुंच पा रहे थे, लेकिन ये व्यक्ति अगर हम तक पहुंच रहा है तो अब हमको डॉक्टर की आवश्यकता नहीं है। और कई बुजुर्ग ऐसे हैं जो कहते हैं कि डॉक्टरी सुविधा से बेहतर है कि हम मानसिक रूप से जो हमारा विकास हुआ है या मानसिक रूप से जो हम सक्षम हुए हैं। अभी हमारे साथ में एक दादा है, इनका नाम नानला बारिया है। और मैं जब से 20 दिन पहले अभी 2-3 बार राउंड में आया तो ये मतलब बेड पे थे, ये बिल्कुल उठ भी नहीं पा रहे थे। मैंने रुपेश सर और मैडम को फोटो उनकी शेयर की थी, तो बेड से वो उठ भी नहीं पा रहे थे, लेकिन हमने लगातार 2 से 3 से 4 बार आए और उन्हें हल्की सी एक्सरसाइज वगैरह, कुछ पाँव की मालिश वगैरह, आप देख सकते हैं उनके पाँव एकदम चमक रहे हैं। मालिश वगैरह और चलना, छोटी छोटी एक्सरसाइज वगैरह की। तो अभी जो दादा हैं वो उनके बेड से उठ के अभी हमारे साथ बैठे हैं। उनका अनुभव, उनके क्रियाकलाप दिनचर्या के ये बताता है कि हम ग्राउंड लेवल पर किस तरीके से बुजुर्गों की सेवा में उनका साथ देते हैं। तो हेल्पेज इंडिया के माध्यम से जो भी हमको बुजुर्गों तक पहुंच सेवा करने का अवसर प्राप्त हो रहा है, तो हम अपने आप को बड़ा भाग्यशाली समझते हैं। उनको दिन में कितने टाइम खाना दिलाना है, कितने टाइम मतलब कौन सा खाना उनको सुपाच्य होगा, किस तरीके से पानी उनको देना है, छोटी छोटी बातों का ख्याल रखने के लिए हमको प्रशिक्षण के दौरान जो चीजें सिखाई गई, तो हमको बहुत ज्यादा मदद मिल रहा है कि उनको घर तक हम सुविधाएं पहुंचा रहे हैं। और हम अपने आप में कुछ सेटिस्फाइड महसूस करते हैं कि आज हेल्पेज इंडिया के माध्यम से हम उन बुजुर्गों को जो एम्बुलेंस या अस्पताल या डॉक्टर्स जिनके घर तक नहीं पहुंच पा रहे हैं, आज हम अपने आप को बड़ा भाग्यशाली समझते हैं कि उनके घर पहुंच तक हम सेवाएं दे पा रहे हैं। और कहते हैं ना कि बुजुर्गों की दुआओं में वो असर होता है कि व्यक्ति को कुछ भी कर गुजरने की एक प्रेरणा मिलती है। तो हम अपने आप को भाग्यशाली समझते हैं कि वो बुजुर्ग हमें आशीर्वाद देते हैं कि बेटा आज आप आए और हमको एक शौच किए हुए शाल या फिर उनका बेड पे जो रहती है या मूत्र किए हुए, टॉयलेट किए हुए, तो वो उनके घर वाले भी थोड़ा हिचकिचाते हैं। लेकिन आज हमको इस तरीके से प्रशिक्षण के दौरान सिखाया गया है कि एक जो स्वयं सेवक होता है उसकी क्या भूमिकाएं होती हैं, हम क्या उनको सेवा प्रदान कर सकते हैं। एक तरीके से हम दुआएं कमाते हैं। तो हेल्पेज इंडिया के माध्यम से जो भी हमको ग्रामीण क्षेत्र में जहाँ पर सुविधाएं नहीं पहुंच पा रही है, हमको उस लायक बनाया, प्रशिक्षण दिया, बुजुर्गों तक पहुंचाया और सेवा प्रदान करने का एक मौका दिया। तो हम हेल्पेज इंडिया के बहुत आभारी हैं। और आप सभी ने मुझे इस कार्यक्रम में सम्मिलित किया, सेमिनार में सम्मिलित किया और बुजुर्गों से संबंधित काम के लिए मुझे उस लायक समझा। आप सभी का हृदय से आभार, बहुत बहुत धन्यवाद। हेल्पेज इंडिया हमेशा ऐसे ही कार्य करता रहे और हम उनका आभार व्यक्त करते रहे और गांव गांव तक बुजुर्गों तक सेवा प्रदान करने के लिए बहुत बहुत धन्यवाद।
बहुत बहुत
जी
शुक्रिया रुपेश और सोनू जी, आपका जुड़ने के लिए फील्ड से डायरेक्टली। और बहुत लोगों को आप मोटिवेट कर रहे हैं और हम लोग आपका हौसला बढ़ाते जाएंगे। आप अपना कम्युनिटी को स्ट्रॉन्ग करते रहिए। बहुत बहुत शुक्रिया आपका जुड़ने के लिए।
जी, थैंक यू जी, थैंक यू सर।
So before I conclude, I think we have some questions and answers that we need to respond to some of the questions. Unfortunately, Dr. Reddy has to go. He has an important meeting to catch up on. So he has left. I'll pass on this question to him and will respond to this question. But we have a question for Mrs. Archana Sharma. So I will read out the question for you, ma'am. So this is written by Adrika. She is stating that the age care report of Helpage India shows that majority of the elderly are not satisfied with the amount of time they get to spend with their families. While majority of the caregiver respond to saying that they spend enough time with the elderly of their family, please suggest some ways to bridge this gap. This is the question. Ma'am, you are on mute.
Yeah, thanks to Dr. Rohit for asking me this question. Thanks, Adrika. So, this is a very good question, and I think there are this one aspect which I would like to emphasize on is repurpose your engagement. The elderly needs to repurpose their engagement. Is it only the complaint is that their children are not spending enough time with them, right? We all know that could be because of their work commitments, nuclear families, their social life, and maybe they're long distance, they're not with them, right? So they're not living in the same house or in the same city or in the same locality. I think we need to create platforms, and Samvedna, actually, when we started Samvedna, we were running a senior citizen center here in Gurgaon, which was basically a hub for seniors to come and spend time with them, time with each other, and engage in purposeful activities. So these could be learning activities, this could be socialization, this could be yoga. We were doing workshops, we were doing digital literacy workshops. We have done a lot of them with Helpage India as well. So I think it's these platforms which need to be created where we can create social hubs for seniors. And I know that there are certain online platforms as well, but so I'm not propagating that don't spend time with your elderly, but I think what I'm trying to get at is that as senior citizens, and we are all getting there, and all of us will be in that age group very soon. We need to find new purpose and engagement for ourselves, and look at peer groups or social groups where you can educate others and you can learn from others. For the families, my advice would be to mark that time, okay? To mark a time of the week or day where you would you would give your elderly that 1 hour or half a day and spend with them. So I can just share with you personally, for me, my Sundays are totally committed to visiting my parents. I spend at least 3 to 4 hours every week. As with them, because I think that's a very small gesture I can do to show to check on them, to socialize with them, and and you know because I know they're living alone, so that they're able to see their children. So that's one thing. Then a small 5-minute daily call. It doesn't have to be a long this thing. A meal, sharing a meal with your elderly, maybe one meal a day, a cup of tea. These are some other things which we can, the younger generation or the children can can try to bring it into their routine. And believe me, once you do it, then you don't feel that you're doing it out of any compulsion. You will slowly start enjoying it as well.
Thank you very much for responding to this question. I think this session is now open for any closing remarks, if any of the panelists do have. So please feel free to share your closing remarks, and then probably I can conclude this webinar.
So would you like me to go first?
Sure. Please go ahead.
Okay. So I think it was a great discussion, very insightful. I learned so much from our other panelists, and Dr. Shivaraju talked about the heterogeneity in our elderly population and different strokes for different population groups. Quality of life, very important. I think that's what elderly are seeking for, is a quality of life, and how we can support them through institutional support or communities, or services which organizations provide. Um, so in terms of long-term strategy, and in terms of what we as a society can help elderly with, is to really see that how we build more sensitization, and we all spoke about that, sensitization for understanding the different kinds of illnesses, the stigma, the challenges of the illnesses, as well as communication strategies, to deal with those particular individuals who are dealing with those illnesses. So that's all I would like to share right now, Rohit. Thank you for having me.
Thank you very much.
Thank you,
Yes,
Dr. Rohit.
Professor Shivaraj.
Yeah, thank you. I think Mr. Manohar is there, who has mentioned about CSR. So I just want to inform that I'm not full-time now with this, but it can be taken up even at ISCON level, and HelpAge is already seeking funds from CSR funds. I think you can also take it up. How best senior citizens associations, their proposals and these things can be provided. So this, I think it can be part of the outcome of the workshop today. So I think that Rohit, you can take note of it. To knock the doors of CSR, website can be the one of the important channels where the senior citizens councils and the associations, their issues can be constantly highlighted, so that they also get the benefit of CSR funds in a limited way, at least in their local areas, if the companies can come forward. That's a good suggestion. They're coming up now, I think, HelpAge with rich experience. What you have done today is very good, because we have to now mention of a lot of issues related to long-term care, because that luxury has gone just to highlight the aging issues. Now we have to understand the reality that they are going to live for longer, and also the care burden is going to increase, and the caregivers issues are coming up in a big way. So it is not only the concern of aging issues, we also should talk about the caregivers, both formal and informal, and institutional care issues, So those things are very, very important. So in that perspective, this, I think perhaps this workshop has given a new insights where we are able to provide and share our experiences. And I think it's a long way. Let's continue. And I appreciate you and congratulate you for carrying out, conducting this very effectively and throwing light on the different issues related to long-term care. Thank you, Dr. Rohit.
Thank you very much, Professor Sivaraju. Dr. Prakash Fernandez.
Yeah, no, just to echo actually what Archana and Professor Sivaraju have said, I think it's really been an enlightening 1.5 hours we've gone through. I really think, action call is really how do we build up these more informal care networks in our communities. I think each one of us can have a responsibility in that. And we've actually tried how do you really integrate it into the community, and yet have that level of supervision, how to escalate your referral mechanisms in place so that it's safe. But I think, if we all need to identify, keep a watch out in our communities, who actually needs this care, who's lonely, keeping tabs on it. I think we can really make that really work of having these networks, which in some places have worked really well. In Kerala, for example, we know where there's palliative care neighborhood networks actually that work. In fact, with HelpAge in Goa, we've been able to kind of look at a more panchayat-based community program where people identify, there are volunteers who identify, befriend. So, there's social networks, there's support networks, and I think there are care networks. And I think each of them will have a place really in making sure that every elderly person gets the support they require.
Thank you very much, Dr. Prakash. I think now I would like to conclude the webinar and would like to say that let us carry forward the insights and lessons that we have learned today. It is incumbent upon all of us, whether we are family members, community leaders, healthcare professionals, or policymakers, to continue advocating for implementing strategies that strengthen the family and community involvement in elderly care. I extend my heartfelt thanks to our esteemed speakers, including Dr. Reddy, Mrs. Archana Sharma, Professor Sivaraju, Dr. Prakash Fernandez, and Mrs. Sanskriti Khare, for their invaluable contributions. Your expertise and passion have significantly enriched this webinar. Finally, I want to thank all the participants for their engagement and commitment for the cause. Your presence and participation is a testament to the growing recognition of vital role of families and communities that can play in establishing a long-term care system in the country. Together, let us try to build a society where our elderly are cherished, supported, and provided with the care and dignity they deserve. With these lines, I conclude this webinar. Thank you very much for joining in.
Thank you, Dr. Rohit.
Thank you, everyone. Nice meeting you.
Thank you, Dr. Rohit.
Thank you.
Thank you.